Okay, so when we are talking about pediatric proptosis, deliberately I've put it as a different category of patients because there are a handful of conditions that will happen in a pediatric orbit, and most of them are very critical. So a PNT is a primitive neuroectodermal tumor, which is very virulent, and it has a certain similarity in histopathology to retinoblastoma. Retinoblastoma, of course, the orbital variation of retinoblastoma, as Dr. Seema Das pointed out. This, if untreated or if you just try to operate it, has survival rates less than 30%. However, and it has to be treated protocol-wise, combining chemotherapy, surgery, and radiation. And of course, we need to look for metastasis. A dermoid cyst is one of the commonest lesions you're going to find in the orbit anywhere. It is not strictly a tumor, it's a structural lesion, it's a hamartoma, and you will very often see this in children. You'll see it growing as the child grows, and it'll often be associated with a suture, most commonly the external suture, but it could also be an internal or medial suture. If it is in the orbit, you may not see a lesion outside, and you're going to see a proptosis. This is another structural lesion which would mimic a proptosis in a child. This is a cyst associated with microphthalmos. And the way to go about it is actually, you don't need to do anything. You're not going to be able to salvage the vision. Later on, you can aspirate the cyst, put in a sclerosant, and later fit a prosthesis. Now, this is something we need to discuss in all children with proptosis. A child presents with proptosis, please do a peripheral blood smear. It may be that within an hour, even without doing a biopsy, you're going to get a diagnosis. This particular child, he's a 12-year-old, had been treated for anemia for a couple of months elsewhere. He's been given blood transfusion, etc., but nobody till now had actually looked at the fundus. So this typical white-centered retinal hemorrhages indicate you have a clear-cut leukemia. But even if you don't have this, and if the peripheral blood smear is normal, you might still find that the child has a granulocytic sarcoma, and the indication might just be anemia and slightly lowered blood counts. Langerhans cell histiocytosis is another condition in a child which is a transitional lesion, which is somewhere between a pure tumor and an inflammation. And it will appear as a very rapidly progressing proptosis in a child. It looks angry, but there's no pain, all right? And it might be mistaken for a rhabdomyosarcoma, but you'll see this very typical bone destruction. And all you need to do is actually an incisional biopsy. A curettage might improve the condition, or a steroid and chemotherapy might also be sufficient. However, in a Langerhans cell histiocytosis or eosinophilic granuloma, you need to check whether there are other lesions elsewhere in the body. So take a look at this child. There is a proptosis, not that much, but the vision is counting fingers. But you look at the lesion, it is a well-formed lesion which you cannot distinguish from the optic nerve. You can see the kinking at the end of the lesion. Okay, this is very typically an optic nerve glioma. And if you find such a thing bilaterally, you need to look for neurofibromatosis. Please do not allow anybody to biopsy this lesion. Very often, when you send this to an oncologist, if they are not aware of the nuances, they're going to say, oh, give us a biopsy. By doing a biopsy, you're actually going to cause more damage. So this child, after chemotherapy for vinblastine and carboplatin at 24 months follow-up, she came in at 1.5 years of age. I have a follow-up up to 4.5 years now. But the child has viable vision. ambulatory vision in that eye. The lesion is not really going to shrink. Okay, even when you image, the lesion is going to be there. But you can improve the viability for the child. A rhabdomyosarcoma is one of the success stories of the last century. We are in the 21st century. It's one of the oncological success stories of the 20th century. When they started off at the beginning, the survival rate was less than 10%. Now it is more than 90%. And particularly in a child, and particularly the embryonal variety of rhabdomyosarcoma, has a very good prognosis. Even when you see a child like this with such a big lesion, please don't allow the child to be exenterated. Because once again, people who are not aware are going to insist on exenteration. Do a biopsy, and if you wish, do a debulking, safeguarding the structures, the recti and the optic nerve. And after a tissue diagnosis, after systemic workup, when the child is put on chemotherapy and radiation, this child, I have more than 7 years of follow-up. Because of the intensive chemotherapy, his growth has been stunted, but he retains a 6/9 vision in that eye. He did develop a radiation-induced cataract and underwent cataract surgery. Even after cataract surgery, he retains a 6/9 vision with normal ocular movements. So once again, what I'm trying to say is we don't really need to be scalpel happy and cut up all eyes with proptosis. Many of them will have indicators that you can do without a surgery. Another set of lesions that almost scream out their own names are the metastases. When you see a child like this, sometimes you'll have the parents once again saying that, oh, the child had trauma. Or another grimmer thing that you might think of is probably this child is a victim of abuse. However, if you take a look, you can see the temporal fullness. And if you look, it's not only one eye that has the ecchymosis. Please take a look at the other eye also. You can see the superior sulcus fullness. And overall, look at the pallor of the child. So something is going on there. Okay, so now when you image, you can see there are bilateral orbital lesions. And you saw the temporal fossa fullness? Take a look at this. There's a tumor within the orbit as well as in the temporal fossa. And you can see that the diploic space of the sphenoid bone here is enlarged. So we know that there is something going on systematically. And let us remember that this ecchymosis around the eye, even though it's present only in 40% of the patients, if you see it, it is pathognomonic for metastatic neuroblastoma. It's absolutely pathognomonic. You don't have to think further at all beyond this. You don't need to biopsy. In corroboration, we have the child has anemia. You saw the pallor, didn't you? Okay. So on USG abdomen, the child has a right suprarenal mass lesion. These lesions are actually, very bad prognosis, and the ecchymosis might finally disappear. Okay, so another metastasis is if you see a lady with a fullness in the right lower lid here, and there's a firm mass, you are talking about a biopsy. This has to be an incisional biopsy because the muscles are involved. You cannot excise the whole thing. And it turned out to be a neoplasm with single file tumor cells. So this is called an Indian file appearance, which is typical for lobular carcinoma of the breast. The treatment is with radiation, and you would also have to treat for radiation retinopathy. It may be presenting with limitation of movement, Did you count in the time that I was not presenting? Another typical feature, this is again pathognomonic of a metastasis. This is called a hang-up-ptosis, particularly in serous carcinoma of breast. You will see when the patient looks down, the eyelid does not move down. Okay, proptosis alone is not going to cause that much of a lag of thalamus. It is desmoplasia inside the orbit. And you can see the lesion here. It might be a more obvious lesion where the patient didn't give us a history of a tumor. But you see the lesion here, you can see the bone erosion. And a rule of thumb is if a tumor is crossing the midline of the orbit, it is a malignancy. So we are looking at a possible malignancy, and just on inspection, I see the scar on the neck. And then the patient comes up and says, oh yeah, there was something in the neck which was taken out 4 or 5 years ago. And then we dig through the old papers, and this is a metastasis from papillary carcinoma thyroid. This is another hang-up-ptosis. So among the bony tumors, this is an example of a mesenchymal chondrosarcoma. Even though it's so-called a chondrosarcoma, you're going to see a bony lesion. Most of the sarcomas will need complete excision. If they're not well circumscribed, this is a patient who's going in for an exenteration. In the lacrimal gland, an example of a mucoepidermoid carcinoma. Now, this is a special case. It's a fairly rare tumor, which can be mistaken for a cystic lesion. You'll see just how well circumscribed this is. Okay? And the other lacrimal gland tumor we should be looking at is an adenoid cystic carcinoma. Once again, you'll see it's crossing the midline, and if you compare the bony orbit on either side, you'll see erosion of the bone. So this is a patient where you would have to do an incisional biopsy. This could be going in for an excisional biopsy. And this would be an incisional biopsy. There can be associated pain and periocular altered sensation if there is perineural invasion. And this might be present in up to 25% of the patients, not in all patients. The treatment nowadays is not exenteration. We would want to do a chemotherapy and radiation. And why so? Because we know that the tumor-free survival after exenteration versus after chemotherapy and radiation is going to be the same. This is another example of an adenoid cystic carcinoma. You can see that it is kind of involving the rectus also. But if you excise it, saving the rectus, and this guy is a driver. I have a 3-year follow-up on him. We've saved the eye. He retains 6/9 vision and his entire ocular movement without diplopia. This is a scan of the mucoepidermoid carcinoma. You'll see these lucent areas. You might mistake it once again for a cystic lesion or a liposarcoma. The thing about mucoepidermoid carcinoma is that it can develop in a pleomorphic adenoma. So if you take an inadequate biopsy, you might think it's a pleomorphic adenoma. However, let's remember our rule of thumb. Because it is well circumscribed, take out the whole lesion. So among the neurogenic tumors, neurofibroma, as we talked about, has a very typical appearance. If you look at a scan, you'll see hypoplasia of the sphenoid wing. A schwannoma, once again, it'll have a slow growth, but it might have cystic degeneration. So it might look like a cyst. And you might have, after excision, you might have some loss of sensation or loss of movement, depending on what nerve it grew from. Optic nerve glioma we talked about. And this is once again a spotter. If there is a hyperostosis, this is a sphenoid ridge meningioma. optic nerve sheath meningioma, if you see an intracorneal tumor where you cannot distinguish the optic nerve, an MRI might distinguish it, and we will know that this typical tram track appearance is once again pathognomonic for an optic nerve sheath meningioma. The treatment is radiation. Once again, do not let anybody take a biopsy from there. I've had patients who were, misguided and had a biopsy and ended up with a worse field defect than they started with. This is not going to resolve with radiation. However, the fields will either stabilize or improve in 60% of the patients. So with that, I come to the end of this talk.